Today's training, this is something that you all have really asked us as the California Bridge team to discuss. It's something that we all see as sons and in the emergency department. And I almost feel like these patients are some of the most complex and difficult patients to really help meet where their needs are. You know, they come in not as patients who are really seeking treatment for their substance use disorder, but coming in seeking help for their chronic pain. And it's a very, very difficult topic for myself, even to this day, for our clinicians, and just for staff in general. So the first thing I want to do is, again, thank you for all your registration forms. They're going to be sent out very shortly, and we will get you all registered and licensed. So, chronic pain and opioid use disorder. So I guess I want to just open this up, and you guys can all type into the chat box. And I might have Caroline, unmute one or two of you. Who are these patients, and why are they coming to the emergency department? So what would their chief complaint be if they come into the emergency department? These patients that have chronic pain and opioid use disorder. Does anybody have any thoughts?
Well, can you hear me?
Yeah, go ahead, Todd.
Well, for me, I'm seeing a lot of kind of, mid-60s kind of patients coming in that have been on chronic pain meds for 20 years, and they go to their provider, and their provider just stops services on them. So they show up here in the emergency department seeking some relief for that, either getting restarted on chronic pain meds or seeking Suboxone to help with the withdrawal symptoms. So it's for my population, it's kind of been more of the older folks that I've been seeing.
Great, yeah. I think Rosemary would like to go next, and then we have Tiffany and Jill.
I also have to agree with the gentleman that just spoke. Some of the patients that I'm getting, they're like 50, 60. A lot of them have been on methadone for quite some time. And through the natural process of aging, are unaware that, you're getting older. So their belief is that they've been on methadone for just the heroin use, so that methadone doesn't work for pain. So they're seeking out the Suboxone to try something different. And a lot of it is just, I've been on methadone for years. I want to get off of it. I'm hearing good things about Suboxone. But yeah, that's mine. I also had one gentleman say that he was tired of getting the looks from his pharmacy. When he goes to fill his medication, he says, they give me this look of, oh, you're here for those. And of course, I don't know how much of it is real, but that's some of the shares that I have gotten. Great.
Well, you might have jumped ahead of us a little bit there.
Sorry.
Oh, no, that's great. That's great. Tiffany said cellulitis, leg pain, and overdoses. Jill said she had someone come in yesterday who was on Norco and extended release morphine, and not so much in pain as she was preventing withdrawal. So again, yeah, these types of patients, they're going to come in and this is what they're going to say. I've never done drugs in my life. And a lot of them are being quote unquote honest. And some of their chief complaints, like Todd said, med refill, I'm out of medication, I lost my prescription. requesting pain medication. One that always comes up, and I'm sure all of our sons and Dr. Jan have seen this, is lower back pain, just lower back pain. My doctor cut me off my meds. Any other ones for these chronic pain, opioid use disorder patients? I know, yeah, Tiffany said leg pain, shoulder pain. Anything else? Dr. Jan, if you do it.
Do you guys see patients that have chronic medical conditions like sickle cell disease, cancer patients, conditions that truly cause a lot of pain, and these patients have been on medications for years?
Yeah, Cynthia just said we've been seeing cancer patients. Tanya said cancer patients all the time. And cancer's no joke, and it causes huge pain. Wow, you guys, a lot's coming in.
Good morning, everybody. This is Cynthia.
Yeah, go for it, Cynthia.
I've connected with City of Hope, and they see a lot of cancer patients. The biggest thing is, yes, their pain is at a high level. Sorry, I'm kind of like blah. But the pain management doctor usually, or not the pain management, but the, oh Lord.
The oncologist?
No, what are they called? I just had a brain fart. Anyways.
Like pain management?
Palliative care.
Doctor.
Yeah, the palliative care doctor I have a really tough patient right now, and the patient is diagnosed with a stage 4. The doctor started her methadone tablets at 90. She's at 95, but the patient is still going out and using black tar. So they wanted to bring her in and withdraw her with ketamine from the methadone, and then turn around and come back and start the Suboxone. So it's been kind of like, these are the complications that we've been experiencing with a lot of the patients.
Yeah, definitely. And again, the transition from methadone to Suboxone, these patients are really, their pain is real. And you almost,
Hey, Mr. Dewey.
hey boss, their pain is real, and you have to understand that, but they clearly do have a substance use disorder. So again, I'm sure you guys have seen and heard these quotes, I'm not an addict, I'm in pain, this hospital doesn't help me, my doctor's a blah, 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 because they cut me off my pain meds.
You're on that.
So, I think for our sons, how do you even talk to this patient? What do you say to them? Do you start bupe? Do you just refill their pain meds and say, go back to your primary care doctor? It's a complicated case and set of cases. And so help me. Christian doesn't know what to do. I have a chronic pain patient who's just angry and wants a refill on their Norco. Can anyone help me here? You can type into the chat box if you'd like. Or Todd, you could help me.
I'm sorry, I fell asleep for a second. What was the question?
So I have a chronic pain patient here who's truly angry and upset and wants a refill on their Norco. And yes, they're withdrawing, but they're fixated on their chronic knee pain and how much they hate all the doctors that have cut them off their meds. How should I even approach this patient?
Well, I approach these patients not from a substance use disorder side of it. I go after, approach it from a chronic pain issue. And what I talk to them about, first I find out if they have a primary care physician. And if they have a primary care physician, then I make some suggestions about some alternative medications, particularly the Butrans patch, which I've seen some amazing outcomes with that. So I'll try to get, if they don't have a PCP, I'll try to get them connected with a PCP and make some suggestions that way. And just try to help follow them through, through the process.
I think that's great. And I'll kind of turn it over to our clinicians, Andrew and Jen, talking about, one, what you as clinicians do with these type of patients, and two, maybe to speak a little bit about that Butrans patch.
So the first thing I try to do is establish rapport with the patient and acknowledge that their pain is real, right? A lot of patients come in and they,
Jen, we can't hear you.
oh,
There you go.
can you hear me?
Yeah, now we can hear you.
Okay, so I was saying that the first thing I like to do is acknowledge that their pain is real. So many of these patients are defensive from the start, and they don't think you're on their team. They don't think you want to help them, right? So they're angry and they're demanding. And I like to say, thank you for coming in today and sharing your story with us. I know you're in a lot of pain, and try to establish that rapport so you're on the same team and working together. And realize that chronic pain is multifactorial, right? It might not just be their cancer or their disease. It could be a social situation, a financial situation, and other things going on. And then I try to start the conversation of how we can best help those patients. Well, we have a lot of messages coming in. Hold on, let me try to read through some of it.
I think Vivian's asking a really good question here that maybe I'll read this question out loud, unless Viviana, do you want to unmute and share this question with us? Because this is one that I would love to hear Andrew and Jen weigh in on.
Sure. Hi, good morning.
Hi, nice to hear from you.
So I do have a couple of patients who I have talked to extensively about, kind of like what happened, how did they get here? And so like one in particular that I wrote about, so she had surgery, she was given pain meds. We talked about how, the doctor said, oh, the pain will eventually go away. She wasn't really offered any alternative. And after a while, she wanted to get off of them, and she found that the withdrawal was bad, and so she started using kratom to control the withdrawals. She told me like how much she was taking, and she said, I only take it to the point where I feel better. I can function. And then she got pregnant, and she was like, well, I know this is probably not safe for my baby, like there's no real like research on it. So then she wanted to start, and then it was, given to her as an alternative to start taking the buprenorphine. But she, I don't know, she just, and every time we've talked, she's never deferred from her story. And like, this is like, she's like, I've never used any, drugs from the street. I've never, I was really just trying to control my withdrawal. And I have a couple of other patients who have similar stories. They're like, I tried to get off of it and I wasn't given an alternative. I wasn't told how to wean myself off. Like, this is the only thing that controls my withdrawal, whatever it is they're taking. And so it seems to me like that is more the kind of patient who then is like, well, I don't have a problem, I just can't get off of this, like, so I don't know, like, am I to believe them? I mean, like, it kind of feels like, you know, there's a fine line, and then they get labeled with opiate use disorder, and it's kind of like there's still a stigma. So they're kind of, like, well, what, is this like in my file? Like, is this in my medical rate? Like, it's just, it seems a bit, I don't know. It's hard. It's hard to like know how do we, believe them, not believe. I mean, yeah, I don't know.
Jen, I see you nodding. You want to chime in here? Viviana, thank you. That was very well put. Thank you.
Yep.
Yeah, we see those cases quite often, and you're right. Sometimes, like, we get so jaded, we don't know who to believe. My personal rule of thumb is trust but verify, right? Like, yes, we have a lot of patients who have chronic pain, but I also have patients who lie about having cancer. I had a patient the other day tell us that he's been on morphine tablets for years because of some GI cancer. And then when we scanned his abdomen finally, he didn't have any tumors or signs of cancer. And he had been to the ER multiple times. No one ever worked it up. He didn't have an oncologist. The story just didn't line up. So, yeah, trust but verify. You're right that so many of these problems were caused by physicians to begin with. Back in the 90s, the 2000s, patient satisfaction and pain control was a big deal, and a lot of hospital administration, bonuses, and physician salaries, referrals, et cetera, were tied to patient satisfaction, and controlling their pain was the most important thing. So then a decade later, physicians realized, oh, we caused an opioid epidemic. Now what can we do to fix it? And in this case, I would absolutely believe this patient. She probably, was irresponsibly prescribed pain medications and is trying to wean and just doesn't have resources. That seems like a failure in her primary care physician and her OB physician when she got pregnant. So basically, when I start opioid medications or treat pain in the emergency department, I use a 3-pronged approach. The first thing is to talk about what alternatives have they tried. There are many non-pharmacologic treatments like CBT, exercise, massage therapy that have been clinically proven to be extremely helpful. And then I ask patients, what non-opioid medications have you tried? Tylenol, NSAIDs, some antidepressants, anticonvulsants, gabapentin. These are all non-opioid medications that in some studies are proven to be equally as useful as opioids. And then I have a conversation about benefits versus harms and try to establish treatment goals with the patient, right? Ask them, what is our goal with your chronic medical illness? Are we trying to make you more functional? Are we trying to improve your pain? And have them understand that, we might not get their pain down to 0. And I always ask, like, what is your ideal level of pain that is tolerable and to make you more functional throughout the day? And then for these patients, you have to assess their risks as well, right? Patients with lung issues, multi-organ dysfunction, people who are older, pregnant, have co-substance use or mental health disease. they're at higher risk of overdose. So I have those conversations with them. And then if they, truly need more pain medication and an opioid, that's okay. But opioid selection is kind of the third piece to this, and that's very important as well. Have you guys heard of the morphine milligram equivalent, and do your hospitals calculate that, for patients? Yeah, so Viviana's saying that you guys are verifying, checking cures and everything. So let me just post this in the chat box. Not all physicians calculate this. We're so busy in the ER, and to take time and look at like how much you're actually prescribing is difficult. But studies show that in patients who are prescribed 50 morphine milligram equivalents a day or more, their risk of overdose and morbidity mortality is at least 2 times higher. So if you look at the chart, there are certain opioids that are safer than others, right? Morphine and intermediate release morphine tablets actually have lower side effects and lower addiction potential than some of the other opioids like oxycodone or Norcos or methadone and fentanyl. So if possible, I try to choose an opioid with lower risk. I'll prescribe morphine intermediate release tablets and tell them to take half a tablet every 4 to 6 hours as needed. They come in 15 milligram doses. And then if I do prescribe oxycodone or hydrocodone, I try to give it separate from Tylenol. So I tell them if you have minimum pain or moderate pain, you can take just Tylenol on its own. And if you have severe pain, you can add the oxycodone tablet. We have a lot of questions coming in, so I'm going to pause my rant and try to answer some of these questions. Christian, are there any that jump out?
Let's see. Viviana asking, I have another question as to why buprenorphine is not prescribed as an alternative to other opioids at this point from the beginning of a patient's care. Is it cost? Is it what's the answer to that?
Yeah, and maybe answer that question second. Just Shelly had a question to clarify something you were just talking about, Jen. Just what is an intermediate morphine tablet? So maybe tackle that one, and then why bup isn't prescribed as an alternate at the point of beginning of care.
Yeah, so a lot of these opioids come in intermediate release and extended release tablets. The extended or long-acting tablets, they dissolve and are absorbed over a longer period of time, maybe like over 6 to 12 hours, where the intermediate release ones are, take effect within a shorter amount of time, 20, 30 minutes, up to 1 to 2 hours. So the intermediate release formulations are overall safer than the extended release. And it's really easy to, confuse these when physicians are prescribing them. We type in morphine and then they'll say IR or ER. And sometimes if you don't pay attention to that, it's easy to just write the ER, but that medication has a higher risk. So I tend to prescribe only intermediate release for pain control. And then the other question was, why is bup not prescribed? So buprenorphine, given that it's a partial agonist, doesn't have as much pain control as the full agonist opioids. Does it still help with pain? Yes, but not to the same extent. And a lot of patients will say, yeah, I've tried bup in the past for chronic pain and it helps with my withdrawal when I was trying to get off of the full agonist opioids, but it doesn't really help with my pain. Is Andrew still on here? Do you have anything else to add about that?
I'm sure he'll chime in when he's ready.
Yeah.
Yeah.
Yeah. Any other questions here?
Yeah, I think we're going to unmute Becky. She's had her hand raised for a while. So, Becky, we're going to unmute you. This is Rebecca Bartley down in Southern California. Hear from you.
Oh, yeah. Hey, I was just saying that I agree with Tanya from Scripps about asking about like alternative therapies. And someone just posted in the chat that Medi-Cal does pay for acupuncture, but you have to find an acupuncturist that actually takes Medi-Cal, which where I am is a struggle. But yeah, just like, you know, treating the whole person, you know, and just not like do you need a refill of Norco? Like I always like to ask patients, like, how well is the Norco working for you? Do you feel like the 4 years you've been on Norco that your quality of life or quality of pain has improved? What is your life like when you run out of Norco? And are you interested in trying something different, such as, you know, buprenorphine, acupuncture, physical therapy, stretching and yoga, like Tanya suggested, surgery? Like, there's no reason why you have to live your life on opiates just because you have pain. Like I have chronic pain. I've gone through this process. I've been in those doctor's offices. So this is something that like is really like close to my heart. And I think like up here, I was lucky enough to source a pain management doctor who's also a addiction medicine specialist. And so, you know, I know that when I refer people to this pain management specialist, like in particular, that they're going to get the care they deserve. But yeah, just you know, like really researching like what's available in your area and what the patient is open to and how the opiate that they're taking is harmful to their life rather than helpful, like helpful versus harmful, you know, like when you're talking about harm reduction, like, is this actually working for you? If not, are you open to exploring different avenues?
Totally. I think that's a great approach. Thank you for sharing that. We have a question from Tiffany asking why intermediate release is safer than extended and how Sublocade applies in this situation. So when I talk about choosing intermediate release, this is to treat acute pain from the emergency department. So say somebody comes in with a fracture from a bike accident, they're going to have significant pain in the next few weeks. And if I, you know, start something from the emergency department, I tend to choose intermediate release. The extended release options are kind of for people who are have more chronic pain, meaning like more than 3 months of pain. It's usually managed from an outpatient setting. We're talking about fentanyl patches, extended oxycodone, morphine, and patients with chronic pain. In terms of Sublocade, so bupe, when we prescribe it from an outpatient clinic, it's to treat opioid dependence, right? Opioid withdrawal, and surely it does help a little bit with chronic pain. I think that's a different arena because, you know, these patients will be on bupe indefinitely, and if there's a formulation that can save them visits to the clinic and they could just, you know, get it once a month, I am in full support of that. There's a reason we don't use Sublocade from the emergency department because I can't follow their care, and we don't tend to give, you know, anything that's long acting or transdermal or implantable from the ER. But I love it for outpatient.
Yeah, Sublocade's a great thing that they're doing in Bridge Clinic right now. Um, it does have, some side effects, especially with patients that, we've seen who are actually those chronic pain patients who don't, quote unquote, aren't high users, you would say. They don't use that much. And so it could have a little bit of the main thing that gets reported is headache. But Sublocade's a great thing for patients, especially, your high risk patients who could lose their medication or they lack transportation or getting to that follow-up is hard, or your really high functioning patients who go to work every day and they can't come in every week or 2 weeks, and so they just want to come in once a month and not miss work that often. They do really well on the Sublocade. So great stuff. Okay, so that was really rich in information, and I think we're going to keep going. We're going to have a couple of case studies. The first thing is a couple of reminders. Again, the Sun contact list via Slack. I will be updating that today. I know some of you have contacted myself and Vanessa with updated phone numbers and emails, and thank you for that. Again, you guys really determined the topic today, so thank you for your input on our surveys. I know we at the Bridge team send out ungodly amounts of surveys to all of you, and we really truly do appreciate you taking the time to fill them out. And I will get to data in a second, but again, if you have any questions or comments about data and data reporting, contact Vanessa or email data@bridgetreatment.org. Elizabeth, if you want to just once again say something about deliverables. I think most of our sons are very on top of this, but again, deliverables.
Yeah, just to say, deliverables are due next Wednesday, so that's just a couple days from now. 1/3 of sites are done. A full third. We're done a full week before the deadline. So if that's, if you want to race to catch up with your Sun colleagues, I encourage you to do that. A reminder about the deliverables went out yesterday. So if you're on this training today and you have not begun this process or have not seen any information about the deliverables, definitely reach out to me so we can make sure that we close that gap. And I'm really excited to have the impact of all 52 sites to share out with the whole world who I think is going to be really interested to hear about this. So yeah, that's my email. I think you all know how to get in touch with me if you need to about your deliverables. And thanks in advance for the work.
Awesome. Great. And then a couple of questions that we have been getting is about data. So just a friendly reminder that data for June is due tomorrow, Friday, July 10th. If you have any questions, comments, concerns, I'll go back to the email data@bridgetreatment.org. We are here to help you with your data. A couple of other things. Yeah, ensure your site is up to date on data for your final deliverables. If your site is missing any monthly aggregate data, you will have already received an email from the data team with the missing months. So please submit this missing data with your June data. I know I got one of those emails. So please submit your data. Yes, Elizabeth.
And just wanted to answer a question that just came in about deliverables. The deliverables have 3 pieces. There's 3 pieces. One is a Zoho form, which is the milestones that are reflected in your state contract and also give you an opportunity to share some input with the Bridge program about how your experience has been. 2 is a financial survey, which is a very, very short form to collect some high-level information about how the spending for your program shifted. That's information you might not have. That's information either your champion might have, or you might have to reach out to someone who administers the grant funding at your hospital. And 3 is the IMAT. The IMAT is the formal program evaluation for California Bridge. So item 1 is to meet your program deliverables and get your final payment. Item 3 is to participate in our formal evaluation process. So there's a small degree of overlap in what the 2 tools are asking, but they're asking them from different perspectives. So if you have additional questions about the difference between those tools, you can reach out to me. You also can reach out to your regional director, who should be very engaged in this process. And what Christian just shared in terms of we're not going to collect data going forward. We are going to continue optional data collection going forward, and there should be guidance going out very, very soon from the data team about that. Unfortunately, neither of them were able to be on this call today, but we'll be following up very soon on that. So, all right.
Cool.
Yeah.
Awesome. Thank you for that. All right. So let's do a couple of case studies now. So this case was actually posted in Slack, and I want to set the stage, and then I'll let Todd take it from here. So this is a patient who is doing quite well. He's on a high dose of methadone, about 90 milligrams, and he needs to get into a residential program. And this residential program does not accept patients on methadone. So the patient needs to get on to Butte. And Todd knows this patient really well. And so this patient comes in, he waits 72 hours, and he has clear active withdrawal symptoms. And I will let Todd take it from here in terms of what happened to this patient. And then I'll have our clinicians kind of discuss 2 points. One is patients on high dose methadone coming into the emergency department. And then the second is really the crux of the story, precipitated withdrawal. So Todd, if you want to take over from here and just let us know what happened with this patient.
Sure. So can you hear me?
Yeah.
Okay. So this was a gentleman, 41-year-old male that I had first encountered in October of 2019. We had some history with him on Suboxone. He wasn't doing well on the Suboxone. He kept going back to heroin use. So we made a plan for him to get connected with the methadone clinic, which he was pretty excited about. And so we got him hooked up with the methadone clinic, and he was doing quite well. But he also uses methamphetamines, cannabis, and alcohol. So we really wanted to get him into a residential program, and we had done the legwork to get that coordinated through the Salvation Army program. So he happened to show up in the emergency department about 6:30 one morning. I don't get here till 9. I walk in at 9 o'clock, and everybody's freaking out. The provider, the nurse, because they had precipitated withdrawal by giving him Suboxone. He was on the 90 milligrams of methadone, had only been off for 72 hours. And unknowingly, as to what was going to happen, the provider did a Cal score, gave him 8 milligrams of Suboxone, immediately put him into withdrawal. So they thought, well, we'll give him another 8 milligrams of Suboxone, and that should clear him up. That wasn't the case. They gave him another 8 milligrams an hour later. That didn't help him. So they did some Ativan, with him, and some promethazine to kind of help with his nausea issues. This guy was miserable. I'm going into my 19th year of SUD work, and I'd never seen this before. We had always taken people down to 30 milligrams of methadone, 72-hour window, and then we started Suboxone with no issues ever. But the provider wasn't, this really wasn't his forte. So rather than, waiting for me to come in or giving me a call, he moved forward. So immediately I tried getting a hold of some of the Sun contacts. I tried to get a hold of some of our clinicians, the UCSF, I think it's UCSF warm line or substance use line. Couldn't get anybody there. So finally, I got a hold of Christian and Tommy. And so we started having some conversation about how to go forward. They made some great suggestions. So I called my clinical champion here for the hospital, and she suggested that we go with a dose of Dilaudid for him. The Dilaudid did help him out somewhat, but he was still really in a lot of agony. And I didn't know, and nobody seemed to know, if we should continue to give opiates to him over a course of time. What we decided to do was to admit the patient. We found grounds to be able to do that. He had some abnormal liver function, liver enzymes, some toxic encephalopathy. So we admitted him. They started him on low doses of Suboxone. I think it was like 2 milligrams over, every 2 hours or so. And he started feeling better over the next day or so, until he got to a point where he really felt great, and he decided to AMA from the hospital. Needless to say, we've recontacted him. We're still working on the plan to get him in residential care. So we're hoping that as we move forward, that we can get him placed where we need to get him placed. So that was kind of how we treated that case, and I hope it never comes up again. And for you that haven't experienced it, it's not a joy.
Yeah, I know Andrew and I have had one of those patients in the ER before. They were on 125 of methadone, and they were 10 days out. And they had a COW score of like 16, and we still precipitated withdrawal. So it happens. Dr. Jan, if you could speak to, I guess the first thing is those high dose methadone patients who do come into the emergency department and they do have a high COW score, that they are showing active withdrawal symptoms, and kind of what to do, or what should we do as, clinicians and as sons. Nothing, give them methadone, give them Norca. What should we do?
Yeah, I've had this case myself at our hospital where a patient on daily methadone missed 2 days. It was 2 or 3 days, and then the provider gave bupe, and he just went into severe precipitated withdrawal. Was then sedated on a Presidex drip, restrained, went up to the ICU. So these are difficult cases. I asked the patient if they want to continue on methadone, or if they're very committed to switching over to Suboxone first, right? Have that shared decision making with the patient. In your case, Todd, the questions I would ask are, one, are there any residential programs in the area that do give patients methadone so that he could continue his treatment with methadone? And then if not, ask the patient if he's interested in switching over to buprenorphine, but warn him that he could have symptoms of precipitated withdrawal and might have to, get treated for that in your department, or get admitted for a few days to get that under control. So a little bit about methadone. So we're kind of like taught on the protocol that after 72 hours, it's safe to give bup, and methadone will be out of the system. Well, there are a few caveats to this rule. First of all, does anyone know the half-life of methadone? Go ahead and put it in the chat box. Just a guess. The half-life is when 50% of that medication will be eliminated from a patient's system. So someone said 2 weeks. Latoya guess 24 hours. So in studies, the half-life is 13 to 47 hours. But see how much that varies? Like, some patients will process 50% of this over 47 hours and others over, 15 hours. So it's very unpredictable. And second question, does anyone know what organ metabolizes methadone? Just a guess. Liver. Ding, ding, ding. So yes, it's metabolized by the liver. And Todd, you mentioned that this patient had elevated liver enzymes and had encephalopathy due to liver disease. So guess what? He probably isn't metabolizing it normally like other people. So it's going to stay in his system longer. Methadone is protein bound. So, bigger patients who are on higher doses chronically might take a lot longer to metabolize this medication. So it's difficult to transition them to buprenorphine. So if this patient was committed to switching to bup, and there are no residential programs that could give him methadone, I don't think it's wrong to give him the buprenorphine from the department, but you have to be prepared to treat the withdrawal. So, don't be afraid to give the full agonist opioids like Dilaudid if he needs. I think in the past we talked about other ways to treat precipitated withdrawal with, ketamine if needed, with benzos, with clonidine, gabapentin, any of those combinations. And this patient might need to stay a little longer to get the withdrawal under control.
Great. Cynthia is asking, and this is a question that actually comes up quite often. Would it be safe to give Subutex versus Suboxone? And is there any difference in that?
So Subutex is just sublingual buprenorphine without naloxone, correct? If given orally, Subutex and Suboxone have the same effect. So when it's dissolved into the tongue, naloxone actually, doesn't have any effect through the GI system. So the naloxone was added to Suboxone to prevent diversion of the medication in case patients, crush it up and try to inject it intravenously. Buprenorphine intravenously has a much more stronger effect, we'll say, and that's when naloxone would kick in to block the effects. So Subutex and Suboxone sublingually in this case should theoretically have the same effect.
And it was actually Subutex that he was given rather than Suboxone. They changed our pharmacy with Adventist Health. moved away from the Suboxone strips to a Subutex.
Yeah, I think at least I know Suboxone, buprenorphine / naloxone is usually just prescribed out. What if you're given in the acute care setting, either emergency department or inpatient, they usually just give the monoproduct buprenorphine. So great. Any other?
The thing, just one last thought. The thing that was important about this case is it was our first encounter with this, and so now our clinical team is going to use this case to set up protocols as to how to approach this in the future. So fingers crossed, it'll come out great for everybody, including the patient. The provider that was treating this case was definitely impacted by it and felt really, really bad about what had happened with this patient.
Yeah, they're hard. They're very difficult patients, and it's like Todd said, it is one of the worst things to see a patient, suffer like that. And everyone's, at least in my case, the patient didn't blame us or anything. They knew we were trying to help. But yeah, it is really, really a complex medical case. And so this next one is actually one of my patients. And I will say before I get into the case, I want to give Julian a shout out because this patient had an insurance issue, could not be seen at Highland in our clinic, and Julian really helped facilitate getting this patient outpatient care where his insurance could see him, and he's doing great. So he's no longer under our care, but he's doing really, really well. And I just want to give Julian a shout out with helping sort out an insurance issue. I know we all hate insurance. So this case is a 32-year-old male with a long history of trigeminal neuralgia. So he has chronic neuropathic pain around his face, and it goes down to his left shoulder. He's been on oxycodone 30 milligrams for years, one every 4 hours as needed. And his cures shows that he gets 150 oxycodone 30 milligram tablets dispensed to him per month. That's a lot. So he comes in and he's basically saying, look, he's very honest with me. I ran out of my oxycodone early. This was over the weekend. I ran out. He comes in on a Monday. His COWS is 11. And he's, I wouldn't say he's demanding, but he's very agitated and he wants help. And he says, Christian, I've heard of Suboxone. I know it's going to help with my withdrawal. But what are you going to do about my pain? I can't go back to work because I'm in pain. And that's why I'm taking more of my oxycodone. And so before I get into what happens to him down the line, I know, again, we're all talking about these types of patients. And Dr. Jan already talked about, morphine equivalency and buprenorphine and treating the withdrawal. But I'd just like either any Sun thoughts or Andrew or Jen to really hop on to talk about these patients who are just so fixated on their pain and they're running out early. So they clearly, he does have an opioid use disorder, but he's never done heroin. He's never done meth. He's never used cocaine. He smokes a little bit of weed, and that's about it. So any thoughts, comments, ideas?
So the first thing that came to my mind was opioids is not the first line treatment for trigeminal neuralgia, right? Carbamazepine in studies actually has the best treatment efficacy for this, and there's a
Hey guys, I'm here, by the way.
Hi Andrew, I see you're on
Hey.
shift.
Yeah. Sorry, we had a good rush of patients, so.
Yeah, we figured. Yeah, so we're talking about a patient with trigeminal neuralgia who's on oxycodone and has chronic pain and opioid withdrawal now. So for this patient, if he's interested in getting treatment for his withdrawals, I would certainly start him on bup and then offer more effective treatments for trigeminal neuralgia, such as carbamazepine. There's baclofen, gabapentin, phenytoin, some antiepileptics that have shown efficacy in studies. And then there's also some procedures that can help, like percutaneous radiofrequency and microvascular decompression. We don't have to go into this stuff, but we should take care of his underlying issue with non-opioids and treat his withdrawals, in my opinion.
Great. Andrew, so I was just talking about a patient that I saw in the emergency department about a year ago, and his chief complaint is chronic pain, oxycodone withdrawal, and he's on Oxy 30, one every 4 hours as needed, and he's dispensed 150 per month, and he's heard of Suboxone. He knows what it is. He knows that it's going to help with his withdrawal. He has a COWS of 11. But he's just fixated on, what are you, Christian, going to do about my pain? I can't go to work because I'm in pain, and that's why I've taken more Oxy than normal, and that's why I ran out.
Yeah.
So what should we do here?
The first thing that we just actually the patient we just saw was talking about pain, and the I think one of the initial kind of pearls is not to lead in with the fact that oxycodone and hydrocodone and Norco are just as addictive as heroin, but to lead with that they're really just bad for you. So the things I talk about are that I say that, basically every time you take an oxycodone or hydrocodone, your body knows that opioid is trying to prevent pain. And so it builds up the pain sensitivity in response to it. So you feel better in the moment, but then over time, your pain just gets worse and worse and worse and worse. And so people over time just become incredibly intolerant to any kind of pain, and they really suffer. So it's just, that's the main problem, is that in the long term, these meds don't work. Then I talk about that they suppress your immune system, so you get infections. That if you're a man, that as soon as you take an oxycodone, your testosterone goes down, and if you take it a lot, it goes down significantly, which makes you feel depressed and just all kinds of problems. And then I talk about how you're more likely to have infections because your immune system is suppressed, and it actually slows down your gut motility, so your guts don't move. And so it means bacteria that's supposed to stay in your gut ends up getting into your lungs. So you get pneumonias. And just overall, when you're taking oxycodone for pain, you're just much more likely to die. There's all these different ways that it hurts you. So I kind of lead with all those things. And then I say, but the fantastic thing is that Suboxone, buprenorphine, is 30 or 40 times stronger than morphine as a pain. And then it was actually originally developed for pain. And it doesn't have all those other negative side effects of producing pain and causing the hormone suppression and all of these other things. And we can give it to you right now. And if you if your pain is bad, we can increase the dose, and I'm sure we'll be able to get you comfortable. So that is the thing with this guy, is you just don't know what he's going to need. Some pain patients really like low amounts of buprenorphine, like they'll be on 2 milligrams a day or 1 milligram 3 times a day. Other pain patients, they need at least 32, and some need more like 40 or 50 a day. So that's the difference with most addiction medicine folks. People really end up ending up in that 16 to 24 range. But chronic pain is just all over the map. It's from really, really low doses to really, really high doses. So that would be my initial approach, Christian.
Great. One thing that Todd talked about earlier that I really want to dive into a little bit is the Butrans patch.
Oh, sure.
And your thoughts on that, especially for pain management.
Yeah. So the Butrans patch is about a half a milligram or a milligram of buprenorphine with no naloxone that is delivered over a 24-hour period. It comes on. There's a little spike where people feel it within like half an hour of putting it on, even sooner. And then once it kicks in, and then it kind of slowly rises and peaks in a day, and then it gradually wears off over the next 6 or 7 days. In the United States, the highest max we can go to is this 20 micrograms per hour, or about a half a milligram sublingual per day. In Europe, they go way up to like 150 micrograms per hour, but we can't do that. So the patch is perfect because you can put the patch on without any withdrawal. You can be on methadone, you can be high on fentanyl, it doesn't matter. You can always place the patch on. I've never had any trouble with that. If at worst, they might feel a little queasiness that comes and goes. Worst case scenario, they can take it off and there won't be a bad reaction. So we use the patch as a way to get started. So this guy's already in pretty good withdrawal, and so he'd probably be okay to get started. But if you weren't confident in that COW score, or something was throwing you off, you could put the patch on him, and he'll probably be able to hang in there for the rest of the day, and then he could start Suboxone the next morning for sure. Like, that'd be a guarantee to do great.
Thanks, Andrew. So I know we're past time here. We'll maybe take 5 more minutes, and thank you to Jen and Andrew for taking the time to be on this training today. As you know, the Sons just find this so valuable. So thank you for the time. We will be sending this out as a recording. So yes to one of the questions in the chat, that we'll send this out as a recording to use as you'd like. And then the other thing that I'll offer that we'll do, Christian, is that you and I can go through the chat. We can download the chat and just see if there were any questions that weren't answered, or put together these resources that Jen shared in a follow-up email. So we'll use your questions that didn't get answered as the basis for future trainings. And I don't actually think we've said this, so just as a reminder, these are not ending. These are going to continue for quite some time longer. So please continue to use the survey link that we send out to tell us what topics would be most valuable to you. And we've been using those directly to plan these trainings. So thank you for your input. And per some of the feedback that we've gotten from you, the next training we'll be talking about substance use disorder in the OB world, which we know is a hot third rail for a lot of people. So we have